Hi, my name is Denise Barrett. I'm one of the clinical educators who works on the tracheostomy and laryngectomy day, and I'm going to walk you through some of the tracheostomy tubes that you will see in NHS Lothian. So to start off with, we'll start with a smaller one, and that is your mini track. Now, it's quite a small tracheostomy tube, used purely for secretion clearance. It's not used for ventilation, but purely secretions. So you'll see these in the ward more often than not. Okay, it's quite small, as I say, and probably size 10 or 12 catheter, suction catheter, would be used with that tracheostomy tube. Okay, second tube we'll look at is our Portex tubes. These are the more common tubes that you'll see certainly in critical care and accident and emergency. Okay, these can be done in the department. The patient doesn't need to go to theatre for these tubes to be inserted. As you can see, this has a pilot balloon which will inflate the cuff of the tracheostomy tube. The size of the tracheostomy tube is on the pilot, and through the pilot balloon we would use our manometer to make sure that the right pressure, the correct pressure, is in the cuff. Okay, so to do that, we just remove the cap and attach the manometer. Okay, so now I'm just going to turn it around to have a look. We want the needle to be in the green. Okay, and it's just in the green there, so it is safe, and we can just take the manometer away. Okay, it's a one-way valve, so not to worry, and we can just replace that little cap there. Okay, so we know the correct pressure is within the tracheostomy tube. Okay, you'll notice there's a ring pull. This is actually the inner tube. So just to be careful with the ring pull, because they can snap, so not to be too rigorous with taking out the tube. And we see the tube, the inner tube of the tracheostomy. Okay, now we need the inner tube to allow us to clear the airway, to give suction therapy. Okay, so one of the issues with having an inner tube is that the inner tube can become full of secretions. So it's recommended within NHS Lothian that we clean the inner tube every 4 hours and replace with a clean tube. So there should always be a spare tube beside your patient. Okay, so I'm just going to pop that one back in. So in the old days, we only had one spare inner tube, so we had to be extra careful and make sure that we didn't dispose of it by accident, the extra tube. Nowadays we have spare inner tubes, inner cannulas at our disposal instead of just the one inner tube being supplied. Okay, so the next tracheostomy tube we're going to look at is the Shiley tracheostomy tube. Now, as you can see, there's no pilot balloon in here, okay, because there's no cuff like our Portex tube, which would create a seal. Okay, you'll notice also on our Shiley, there's a hole, if you like, in our tracheostomy tube. This is a fenestration. This allows air to reach the vocal cords and allows the patient to speak. So we'll see these tubes mostly in our patients that we're weaning and wanting them to speak. Okay, again, the size of the tracheostomy tube is written on the tracheostomy itself. Okay, easily identifiable. There's an inner tube also, and it has a locking mechanism, so the two dots there need to be aligned to ensure security. Okay, so I'm just going to unscrew it here and take it out. So that's our inner tube. Now that's going to allow us to suction our patient, and you'll notice that on our inner tube there is no fenestration, there's no hole. Because of course if we were to suction our patient with a fenestrated inner cannula, the suction catheter may end up going through the fenestration and damaging the surrounding tissues. So always a solid tube with no fenestration with these tubes.
When you're suctioning, yeah.
When you're suctioning, yeah. Thank you. Okay, so that is our Shiley. Alright, these are latex free. Okay, next up we're going to have a look at our adjustable flange tracheostomy tubes. So these tubes would be used for patients who have had severe burns, or patients with larger necks, or patients who have suffered anaphylaxis. So we need to make sure that the length of the tracheostomy tube is adjustable as the patient improves. Okay, so there are two types of adjustable flange, and you'll notice this particular one I'm showing you has a latch. So we would have the size measured out for our patient, and then we secure it by using our latch there and keeping the tracheostomy tube length secure. It's part of our safety checks. It would be a very good idea to have that written on the signage for our patient, or our tracheostomy patient, or if you work in critical care, that will be part of your safety checks at the length of the tracheostomy tube. Okay, so as you can see, this has a cuff which will create a good seal for ventilation, and our pilot balloon which will tell us again the size of our tracheostomy tube. Okay. This one has an inner tube, again the ring pool. So if there are secretions, that's an issue, then we're able to suction our patient and change our tube, make sure it's clean. The other version that we have is where we secure the length of our tracheostomy tube. This one's a screw version, as you can see. So it takes a bit of doing to undo that. So you can probably see some of the safety issues that may crop up with your patient. The latch seemed a bit easy to move, so again, part of our safety checks is to make sure that latch is in the correct place.
And just to say as well that the length that the latch or screw is at is a decision by the medics. We don't ever adjust them, we just make sure that they're secure. And also these are put in surgery rather than in the bed space. Even in critical care, the patient would go to theatre to get these types of tracheostomies inserted.
So the last tracheostomy tube I'm going to show you is called the Bivona tracheostomy tube, and you'll notice that it's quite flexible in comparison to the other tubes that we've looked at, which have been pretty rigid. Okay, the reason for the silicone is for patients who may have a very sensitive trachea, or are long-term patients. So we would probably consider using Bivona tracheostomy tube. So these can be cuffless, as I'm showing you here, or they may have a cuff. Okay. So our patients will need to be very stable to be able to have the cuffless variety and able to clear secretions. Because if patients are discharged home with their tracheostomy tube, they've got to be able to clear secretions. Okay. These are gas permeable, so if we were using a cuffed tube, we would probably inflate the cuff with water as opposed to air, so it doesn't get absorbed. Okay. The decisions on which tracheostomy tube to be used is really up to the anaesthetist. They will always make that decision. We would never make that decision. Okay, so just a couple of safety points to mention. When we come on shift, we're going to check the pressure within the cuff of our tracheostomy tube. So to check the pressure, we're always going to use our manometer. Okay, and make sure that the needle is within the green zone. The temptation is to give our pilot balloon a little squeeze, but if we were to do that, you might notice what's happening in the patient's trachea. If I squeeze that, the cuff is causing undue pressure to the tracheal tissues. So if we were all doing that, you can imagine the damage to the trachea. So to avoid squeezing the pilot balloon, and to always use our manometer.